It's my honor to welcome all of you, graduates, parents, and families, faculty, and staff to Mount Sinai's 44th commencement. Give yourselves a huge round of applause for what you've achieved. Today is not only the 44th commencement, but today is a very special ceremony, and is the first graduation of a class under the new name of our school, the Icahn School of Medicine at Mount Sinai. I'd like to extend my personal thanks and this institution's enduring appreciation to our trustee, Carl Icahn, for his generous commitment to our students and our school. Mr. Icahn's support will resonate in our classrooms, laboratories, and hospital, our doctor's offices, for generations. For nearly 2 decades, he's been a most generous donor, as reflected in the presence of the Icahn Medical Institute on our campus, and his support for gene therapy, and more recently, for the Genomics Institute, which now bears his name. His gift to name our school reflects his continued support and belief in the preeminence of this institution. Now to a more serious note. Graduates, America is on the cusp of dramatic change in the way we practice medicine. And as we have all read or heard, our country cannot afford the costs of our healthcare system. A robust national dialogue is now ongoing, but already a consensus has emerged that our healthcare delivery system must change. That view is based on these stark numbers. Today, healthcare costs top $2.6 trillion and represents 17% of our gross domestic product. By 2020, it will approach 20% of GDP. This is clearly an unsustainable trajectory and a level of GDP that is not equaled any other place in the world. Change is inevitable. In fact, changes are already occurring that will make this system more efficient and less costly. And the most visible change is in the care coordination that is now taking place between doctors and case managers, nurses and social workers, outreach coordinators and at-home providers, indeed, in every member of the care team. But at an even more fundamental level, the change that actually drives the necessity is the necessity for care coordination. And it is the movement away from the traditional fee-for-service payment system. Under fee-for-service, doctors are reimbursed for the number of services they perform, not for the outcomes they generate. In fee-for-service, doctors can order redundant tests, unnecessary tests, make inappropriate referrals, and simply add cost without adding value. It has even been argued that there is a de facto disincentive to spend a lot of time talking to patients because the doctor who does ultimately will create fewer bills. But most of all, and even for the best doctors, health care in our current fee-for-service system is not coordinated, nor is it efficient. Consequently, readmissions, emergency department visits, and other preventable conditions occur simply because the system has inherent deficiencies that do not optimize care. Taken together, we now recognize that we must find a way to align providers, payers, and patients. Although we're only at the initial phases of restructuring American healthcare, here is what we know the future will increasingly look like. It will emphasize prevention. It will feature coordination among caregivers, patients, and families. It will rely on teams of people with many different skills and licenses, each working up to the maximum that is allowed under their license. The Affordable Care Act, or Obamacare, though largely concerned with expanding access, has taken an important step with pilot programs that are taking hold around the country to realign healthcare and move us out of the fee-for-service system. The first step is the shared savings programs. Shared savings programs reward providers who stay below spending goals for either an entire population or a single episode of care. At the same time, providers must meet clearly defined quality metrics. One such shared savings program is the Accountable Care Organization, or ACO. For each ACO, Medicare sets a spending target that represents what would be a cost saving over prior years. If that goal is reached, the ACO receives half of the savings. Mount Sinai today has an ACO with 25,000 members. We're the largest ACO in Manhattan and the second largest in the state of New York. It has been nearly a year since it opened, and already we have generated significant savings derived from decreased readmissions and decreased use of emergency services. We've achieved this program through a coordinated care program that has as its backbone case managers who are intimately involved in patient care. This large and growing team is supported by a robust IT platform and an electronic health record. Data from our electronic health record helps case managers identify problems every day, and they are in contact with patients almost every day. But the real value, the true paradigm shift, is that these shared savings programs align payers, providers, and patients. Everyone has the same incentive. Everyone in the healthcare ecosystem all have those same alignment, the same incentives. And those incentives are to prevent disease, and when disease occurs, to treat it as efficiently as we possibly can with the highest quality care. The power of this alignment, when adequately appreciated, will be felt as a strong gravitational pull away from fee-for-service and toward population management. Consequently, at Mount Sinai, we are intensely focused on this model and are preparing our institution to manage populations in systems beyond Medicare and to build upon our Medicare ACO. But here's what I want to caution you all about. A shared savings program is not without risks to our healthcare system. It can be viewed as a system whose incentives are to do as little care as possible. It can look like a grotesque inversion of fee-for-service, where fee-for-service incentivized doing too much, shared saving incentives could incentivize to do too little. Hence, the quality metrics that are linked to shared savings programs are absolutely crucial. And we have to make sure that they are robust, that they need to guarantee state-of-the-art care, and that they are met. To date, quality measures are a central feature of the ACO. There are no shared savings unless those quality targets are achieved. We want to make sure that the future is the same. There are other concerns. As shared savings programs expand and population management becomes the dominant form of healthcare, we must stay cognizant of a number of crucial circumstances. Specifically, the nation's frayed social service network is riddled with holes that the community must perceive and our patients routinely fall through. Incentivizing doctors to keep people well sounds like a good idea, but it rests on a whole host of factors that can be beyond our control. For example, whether patients are taking their medicines correctly, whether they're keeping their appointments, whether they're exercising and maintaining their weight, whether they are getting enough sleep, whether they're adequately housed, whether they're receiving adequate food, and whether they're doing things like quitting smoking. You must ask, can doctors control these factors? Can doctors really help patients adhere to care plans and live healthier lives? The answer is no. Doctors alone cannot help patients prevent or manage chronic disease. They cannot make sure that prescriptions are filled and taken accordingly. They cannot help complex patients, the uninsured and the underinsured, people with multiple conditions and complexities, overcome all the barriers to care and receive improved care. But a sophisticated, dedicated, coordinated care team where everyone is working to the maximum of their license can help ensure those outcomes. You will be a critical member of those care teams. Indeed, often the leader of those teams. But even the best teams will sometimes have poor outcomes because of circumstances beyond your control. In those instances, it is also your responsibility to educate our policymakers and politicians that they too must accept the responsibility for poorer health outcomes in underserved communities. They must not simply take the easy road and blame the healthcare system for poor outcomes. So, taken together, the class of 2013 faces enormous challenges and revolutionary changes. How will the graduates in this room respond? As I mulled that, a famous Bob Dylan lyric came to my mind, which I hope some of you remember. He wrote and sang, "You better start swimming or you'll sink like a stone, for the times they are changing." I know this class. I know what you've been taught. I know the values of our institution and the values we have communicated to you. And for that reason, I'm convinced that you will not sink like a stone and you will start swimming. Congratulations, good luck, and make us proud as you go forward.